Hi, welcome to my podcast. My name is Dr. Brendan McCarthy. I'm the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning in my podcast. I love you being here with me, and I love doing this. Before I do an episode, I always sit back and I reflect on why I'm doing this episode, and I like do a little meditation on it, and I visualize the individual who I want to be helpful to. I think about what she's going through. I think about the questions that she's asked in the past where I've been in the clinic with her. I think about the questions that I've gotten when I do a podcast and the reels that come out, the questions I get. I think about those women and what they say, and I want to be better. Every time I do this podcast, I want you to know I just want to be better. You know, why that is because, every time I listen to your questions and I focus on this material, it helps me grow as a physician. You can't help but get better at the practice of medicine if you're constantly applying yourself to become better at it and to become more clear with it. So I want you to know that's one of the other benefits I get from this. I'm not going to sell you on anything because I don't want to do that. I want you to know what I'm really getting from this is the chance to consistently refine the way I communicate this. So this episode is a bonus episode on progesterone. I didn't think I was going to do it because I thought the first ones were good. And then reading your comments and just really thinking about you made me realize it's not done yet. I need more. I need to put more into this. So I want to talk to you specifically about pharmacokinetics of progesterone because you deserve knowing this. There's so much confusion about this, even among physicians, especially among physicians in a way, I think. And that's the frustrating part because I'm going to sit here, I'm educating you, and you have to educate your doctor. And you're like, well, Brendan, why aren't you trying to educate the other doctors? Uh, they, if they wanted to know, they would know. I think coming from you is better. I do want to be helpful to other physicians. I want this to be helpful to them. I want to be supportive of their growth in this field and understanding the material in front of them. But a lot of times you just kind of try and communicate with physicians. This is a better way of doing it. And there's a whole oppositional thing that happens. And I don't really feel good about that. I personally feel better that if my actions help empower you further as a patient to know and become more educated, I personally feel stronger about that. I think that I'm being a better advocate by further empowering you and having you have more information in your hands. So that's what this is. To the degree that you like this material that I'm about to share, press the like button. And if you think that this is going to help someone share it with them. If you like the way that I'm doing what I'm doing, subscribe. Keep up with me on this. And as always, your comments are welcome. And I know I don't watch my YouTube comments at all lately. I'm sorry. It's a lot of stuff I got going on with patients and work and family and kids and being a dad and being a husband and all the stuff that goes into my life. And so I probably don't look at YouTube comments like I know I'm not looking at them like I'm supposed to. Okay, I need to look at them more. With that said, I do read Instagram real fast because that's like real quick and I just seem to gravitate towards those comments. I just want you to know your comments are read on the regular and I learn from them. But not just me. I see you guys talk to each other always. And I love the way you support one another. You are amazing women. I'm very fortunate to be in a space with you where you allow me to be a part of this. And the way you support one another is remarkable. And I've been doing this for 3 years. I've had no trolls really to speak of. I mean, every once in a while you get a guy on who says something weird or something. People comment on my earrings or, I get weird things like telling me I look like Elton John, which is not an insult. I like Elton John's music. Elton John's, I'm that generation. Elton John's, who doesn't like Elton John's music, man? I mean, I get funny things in there. But what I do see on the vast majority is honest care. honest care for each other. There's a gentleness with each other that I see you sharing, and I'm truly thankful. All right, pharmacokinetics. What the heck is that, Brendan? Why is it important, Brendan? It's critical. When we approach you in the perimenopause state from mid 30s, say, until menopause, late 40s, 50s, whatever that window is for you, you're all unique. But when you start having those anovulatory cycles, which means you're not ovulating, you're not generating as much progesterone, there's a lot of different facets involved in this. But say you're starting to hit these points where you have diminished returns, you're going to have lower and lower progesterone. You need progesterone. Part of your biology, part of your makeup. It's who you are. Now, there's redundancy in your body. There's other things you can do that help. But at the end of the day, your body was made to have progesterone. It's a good thing to try and get that back on track, either you making it naturally or me doing my best to help get it into you naturally. Getting it into you naturally is my job. Getting it into you in a way that is natural to your body is my job. Having a doctor just prescribe you progesterone is not enough. Your doctor needs to understand how the progesterone goes from the format you're getting it in, pill, troche, cream, whatever. How does it get into you, and how does it get to the progesterone receptor? And what happens between here and there? That is my job. That is every physician's job. And this is where all the mistakes are made. So I'm going to talk about the pharmacokinetics of progesterone, which is when you take the progesterone and you take it into your body, how does it get to where it belongs? Why is this important? Many of you who take progesterone have that reverse response. And I want you to know in the world, it's not a huge percentage. It's actually small, but why you see it's being so vocalized on my page is because it seems like you guys don't have a platform to talk about it. There's very few platforms that really you have to speak on this. So I want those of you who've never heard of this, who've never experienced this, I want you to know that the population that you're seeing right now being very active on my site, on my Instagram feed and YouTube, I think, but I haven't really looked at it lately, I'm sorry. But if that population of people this is their opportunity to truly speak what their experience is. It may seem like that's all people are having problems with progesterone. It's a segment. It's a very valid segment though. So, what is it that we want to do? What is it that I'm trying to do with this? I'm trying to communicate this in a way that when you take progesterone, how it's going to get to the brain and how it's going to get to your uterus and how it's going to get to your breasts, because that's the important stuff. Okay. So, routes of delivery of progesterone. When your doctor prescribes progesterone, and I've already released videos on why we would prescribe it and the reasons and the labs and everything. So, I'm just going to go over the methods of delivery and what that does and what that means and why that's important. That's my goal today. So say we start off with the progesterone. We're going to be doing, I'm going to talk today, I just wrote my notes to make sure I don't forget anything. I do oral, it'll be vaginal. I'm going to talk about rectal. I'm going to talk about intramuscular. I'll talk a little bit about subcutaneous and transdermal. I'll mention a little bit about intranasal, intrauterine. I'll talk a little bit about intravenous. These are not routes I generally use, but I will talk about that sublingual one, which is the most common one I use in practice. There's a reason for that. I'll walk you through everything because me just saying sublingual has the best absorption isn't clear enough, I think. Again, this goes back to me refining. I want to be better for you because when I'm better for you, I learn to be a better physician because I'm a better communicator. So to the degree I'm doing it, let me know. I'll be watching. Comment on Instagram. I'm working on my YouTube skill set. Okay. Oral bioavailability, there we are, of progesterone is very low. Progesterone, when you swallow it, you're getting the lowest absorption, period. And that has to do with the fact that the molecular size of it's not very easily absorbed. It's also lipophilic, meaning it's a fat soluble compound. And if you take that orally as just regular progesterone, if you didn't do it with food or something that's fatty, your absorption rate's going to be very low. Okay. Now, over time, they've adjusted this, and you'll see a lot of times we're using something called oral micronized progesterones. They micronize it. They mill it down to very small particulate size, which makes it easier to absorb. So oral micronized progesterone, it's because it's that really tiny little flake, that little tiny little particle, you get good absorption. That's why they do the pill version of it in that format. Another one is going to be like Prometrium, where they mix it in oil. It's in an oil suspension, easier to absorb. So those two oral formats that you're going to take in and swallow, that's what's out there in the market. They're still not the most absorbed when you swallow as a pill, but they can be absorbed. What happens when you take it in? When you take in the progesterone orally, either micronized or in a liquid oil cap, it's going to immediately have first pass effect through your liver. What is that? When you absorb things, food, take food, let's talk about food, because that's what this whole process is meant to be for when you eat something. So you're eating that pill, it's sort of like eating food. So you say you eat like a cucumber, a couple slices of cucumber, that's your lunch. And you should eat more than that. But you eat a couple slices of cucumber, your stomach acid, first salivary amylase enzyme up here starts breaking it down. There's a little bit of carbohydrate in there to break it down. Then you get into your stomach gas is going to hit it next. That's going to break down proteins. The girl will break down proteins and amino acids. I know cucumbers don't have a lot of protein there. So you're going to then break it down further. Then it goes into the small intestine where the pancreas releases enzymes. These enzymes are going to further break this down so you have better absorption. And then it gets into circulation. It's called portal circulation. It's drawn into the liver. In the liver, it starts getting broken down even further. Okay? When you take a pill of progesterone, all those enzymes don't touch it. Stomach acid doesn't really touch it. The enzymes, pancreatic ones, doesn't really touch it. So it gets absorbed relatively whole as progesterone, and it gets into your liver. Now, your liver starts to metabolize it right away because it's like, that's what it does. It's not used to seeing hormones orally. Now, progesterone taken orally and swallowed is a safe route. Meaning, when you take in estrogen orally, that first pass through the liver, it converts a lot of it over to estrone, and estrone's an inflammatory estrogen. A lot of health problems with that. That's a concern. When you take in testosterone orally, you're going to convert that over to dihydrotestosterone like a boss. It's also hepatotoxic, so you don't want to do those two orally because you're going to have way more side effects and not much benefit. When you give a woman progesterone as a pill and she swallows it, the first pass, most of that progesterone is going to be bioconverted into the downstream metabolites of progesterone. Alopregenolone being one of the big ones. Pregnenolone is another one. There's a couple other metabolites, but the ones that have the best bioactivity is going to be the allopregenolone. That's the one that has the most bioactivity in there. When a woman has a reverse responder, when a woman responds to progesterone, instead of having calmness and relaxation, and she does the exact opposite, is because her allopregenolone triggers her. There's a couple of reasons why, and I've mentioned that in the previous episode. I don't want to dive too deep into that. But the thing is, when you swallow the pill, you're going to really ramp up the allopreg, and you're going to have the person who doesn't do well with allopregenolone having those bad responses. Most of you who take in oral progesterone you swallow as a pill, you're going to have a ton of allopregenolone, and you're going to sleep like a baby. It's amazing for that. Allopregenolone by itself is so important in my practice. For those of you who do well with allopregenolone, those of you who do well with progesterone metabolism, allopregenolone is my favorite. It's an anti-anxiety agent. It's the thing that makes a big difference in your brain chemistry. Without it, your brain is more wired towards stress and anxiety. Without it, you don't make as much serotonin, and the downstream metabolite of that being melatonin. Without that, your GABA receptors are not going to. So allopregenolone binds to the GABA receptors, which is the part of the brain associated with anxiety, and it helps quench that anxiety, helps calm that down. Allopreg is critical stuff. But when I'm giving you progesterone, going up here to the brain is only part of what I'm trying to do. What I really want to be doing is getting a mix of the allopregenolone and progesterone, because I need the progesterone for your uterus and your breast tissue. I need that progesterone to do its job. So if I give it to you as an oral pill, you take that in, you're going to have more allopreg, you're not going to have as much progesterone. What if I were to do it differently? What if I did topical? So if I do topical cream on your skin, not very much absorption. The reason why is the keratinization, or the type of skin you have on your arms and your inner arms and stuff. A little better absorption in your crease of the arms and thinner skin. You get a better absorption, sure. And inner thighs and you apply it transvaginally, topically, around the labia, et cetera. That can be absorbed pretty well. Better if we're doing that instead of transdermal is to do more of a suppository. And you could do that if you're not sexually active. You would do that transvaginally, or if you're sexually active, you want to do it rectally. Why did I say that? If you are sexually active and you put progesterone transvaginally, it will get on his penis. When you put progesterone or any hormone transvaginal, you have a higher rate of conversion or spread to your partner. And that's important to be aware of. So transdermal and transvaginal or rectal, right? So the two suppositories that way, or topical cream, very similar, very similar. The cool thing about it, it's not going to have first pass through the liver, right? So it's not going to have the first pass through the liver, so it's not going to be hyperconverted to allopregenolone. Those women, for sure, we're going to get the benefit dermal or rectal or vaginal. It's going to get the benefit to the uterus and it's going to get the benefit to the breast tissue. So we're having that. That's a good thing. With that said, if you look at the graphic here, you're going to see that transdermal, transrectal, or transvaginal, you're not going to have the other downstream metabolites. You're not going to make as much pregnenolone with it. Now, is that a bad thing? Not really, not necessarily. Think about how your ovaries are going to make progesterone. The ovaries make the progesterone, and then it crosses the blood-brain barrier, turns to allopregenolone. So doing it transdermal, transvaginal, transrectal, you're going to still get the progesterone in the system. It's still going to cross the blood-brain barrier. It's still going to be converted to allopregenolone. You're still going to get the benefit, okay? Why do I always talk about sublingual? Sublingual is a hybrid. Sublingual is a hybrid. When a person puts the progesterone under their tongue and lets it sit there and fully dissolve, okay, they're not going to get hepatic first pass. That progesterone up here in their mouth is going to transfer through the gums faster, or the tongue. It's going to transfer faster than it would on the skin. Probably on a par, I think it was on a par last time I looked at the research, it's going to be on a par with what happens transvaginal and transrectal. Why do I still prefer sublingual? Because it's easier? There's that too. But it tastes icky, dude. It does not taste good. No one likes the taste of this stuff. Michelle, Dr. Glenecki, is brilliant chemist. She's the one who formulated our progesterone to have the least amount of bitter flavoring to it. She's a natural compound with that. She's wicked smart, but still, it does not taste great. So that's not it. Well, what is it? No matter how hard, I want you only to absorb it transbuccal up here in the mouth. I still want you to swallow a little bit of that saliva. I know it's going to happen. So I'm going to get still some of that progesterone. It's going to get down into the liver. It's going to be bioconverted into allopregenolone. So I'm getting the best of both worlds. As you can see here in this graphic, you're going to see I get my progesterone. I get my downstream metabolites. This is what I want. Why is it that I want that and not just make it look very natural with a transdermal, like a rectal, vaginal, or skin? When women come into my clinic, women in general, my observations, my time in the room with you has helped me understand more. There's so much stress women go through. I'm not pandering to you. I'm being very honest. And I know sometimes when I go down this road and talk like this, I do get some comments saying, like, you have no idea what you're talking about. You're a guy. I know. That doesn't mean I don't feel you, hear you, or care about you deeply. Deeply. How could someone not care about you deeply who's in this position as a physician? How on earth is that possible? These women present to clinic after years of PMS, someone with PMDD. They also have PTSD, a lot of P in initials in here, but they do. There's a lot of trauma involved in this. Just because it happens to you every month doesn't make it normal or right. It's still a traumatic thing for many, many, many women. When I use the version I use, I kind of want the allopregenolone in there to kind of do a little pop, so long as they're not reverse responding. I want that little pop because I want that ability to help them up here. I want them to get that sleep. I want them to have that anxiety component calm down. I want to be helpful there. This is why I use that format. This is why it's my favorite format. When people want to do really weird versions like subcutaneous injections or intramuscular injections or intravenous, which I've never seen. Any of the other stranger routes of delivery, intranasal, which is a weird one too. Um, the reason I don't know why they would. I'm not even going to pretend to know. The fertility. I know fertility. You want to ramp up the progesterone pretty high, so they do a shot with it. I get that. There's roles there. But for the stuff we're talking about for treating, hormone replacement therapy, peri and postmenopausal, we don't need to do anything crazy. Just the ones I mentioned: transvaginal, transrectal. I prefer not transdermal because you will spread it to the people in your life around you. I prefer you to be aware of what that progesterone is doing transvaginal and transrectal as well, to making sure you don't give exposure to an individual who doesn't know. And even if they do know, I don't think it's a wise thing to put, because we give men progesterone to prevent premature ejaculation. That's a little thing it does on the side. It's kind of nice, but that's still, your medicine's for you. We don't want going to other people. So those routes of delivery that I'm recommending, I think, are the most important ones to discuss. The other ones are available. They're out there. There's benefit to them. There's, like I said, fertility for the injections, but let's stick to mine, okay? This is something I want you to know that you deserve. No doctor should ever put a hormone in your body without running a lab to verify that you needed it. And no physician should ever prescribe a medication to you without running a lab within a month to verify what it did and if it was the correct dose and absorbed. It's too often that these doctors will charge you for this appointment and you come in there, it's like $800 or something, and they don't run labs. They just say, you have these symptoms, I'm writing this prescription. And they write you that prescription and they don't run a lab with you to verify it did its job. And I've seen them argue this, and I get so frustrated because we need to know what it does. Why? Because what if it's so here, this is why. When you take oral progesterone, the one you swallow, and I run your labs, okay, I want to know whether that's all being converted to Alopregenolone or you have enough progesterone to protect the breast tissue. I want to know if I'm getting the right amount that's going to be protecting the line of the uterus. I need to run my lab to verify that. Otherwise, I'm just guessing. Sure, I can overload you with it and give you like 600, 800 milligrams progesterone, but what on earth is that? That's just throwing it at you and calling it a day and going home and cashing a check. That's crap medicine, bad medicine. I'm calling it out. I really am. And it's because you are someone's mom. You are someone's daughter. You're someone's sister. You're someone's wife. You matter. You deserve this. And anyone arguing otherwise, send them my way. I'll straighten them out. But just remember this. I promise you, you deserve that work. It's too often I see women go for years and years without lab work, and there are so many side effects and problems that could have been managed. And you deserve that. So the lab work to me is everything. This is why. And if I can't get it covered by insurance, I have other lab companies I use that give us great discounts. We can navigate that with you. And if your doctor doesn't try navigating that with you, maybe we should find a different doctor for you. When I run labs, I want you to understand the labs. This is everything. This is another one. Get out your pen and paper, write this down. Just remember this. There's two ways of testing progesterone in a woman, okay? There's the cheap way, which is going to be used immunoassay. And immunoassay, it's just the run-of-the-mill, easy, low-cost test. Then there's going to be the thin layer chromatography mass spectroscopy, mass spec. Why? What's the difference? The immunoassay, when I run that lab and I test for progesterone, it gets confused and it bundles into that test result the Alopregenolone. And it bundles in there a little bit of the pregnenolone. It always gets the number wrong. It's more combined telling you both. So if you take oral pill version of progesterone, you swallow it, and you do a progesterone lab a month later, it's going to look great. But then you're like, why am I having breakthrough bleeding? Why my breast hurts? What is this? Why is this not working? Or those of you who are responders be like, I feel like I'm going crazy today. What is this? It's because they're not getting the full picture. So when you do the other version, the mass spec version, that's when you get the best results. That's most precise. That's the test you want. Let's get sassy with this for 1 second. Let's be smart together. Let's be clever together. Let me share this with you. When a woman presents to clinic and I don't understand why she's not getting the benefit of the progesterone to help her sleep, or she's taking the progesterone and I don't understand why she's irritable, anxious, or upset when she takes the progesterone, when I get confused about the woman in front of me taking the progesterone and it's not doing what I thought it would. Normally, if it was like testosterone, I run dihydrotestosterone. I know how to test for testosterone downstream metabolites, easy breezy. And all those labs are available. I can't test Alopregenolone. There's no labs that'll do a serum Alopregenolone. I don't have any companies that do that. And even Dutch test doesn't do it. So you guys be like, oh, do Dutch. No, Dutch doesn't do that either. What do? Think about this for a second. If I take that woman, I run day 21 labs when we're taking the progesterone, and I run the immunoassay and the mass spec version of that lab, the difference between them helps me understand what on earth the metabolites are. So say I gave that woman progesterone, and her progesterone was a 5 on immunoassay, and it was 2 on the mass spec. I know that 3, the difference between the two, is going to be being converted over, and that's allopreg or preg or dihydroprogesterone. It's all these other metabolites it could be instead. That's when I'm being clever. Because some women, even though they put it up here and let it dissolve the best they can, they still swallow it. Some women, even though transvaginally everything should be fine, their body shouldn't convert it, some reason or another they may hyperconvert anyway. We should always work very hard to be clever for you. So running the lab that way, I think, is very important, that you know that's possible, but also that you know there's 2 different labs, and you really need the mass spec version of it. That is the most important one. If you can't get that one, just know the route of delivery. We need to push for that delivery system to be one that does nurture the breasts and the uterus, and make sure everything stays within the line of the uterus is intact, is not being overstimulated by estrogen, and same with breast tissue. You want that progesterone to be present there. And if we're just using, the most basic test, immunoassay, we don't know for sure if it is. So we should, when we do that, make sure we're doing it transrectal, transvaginal, or sublingual. I know sometimes when I do these videos, I see myself getting frustrated and angry. And it sounds like and I know it comes across as arrogant. And I know. And it's more that because I'm not. I mean, if you're hanging out with me, you kind of realize the kind of guy I am. I don't have that operating system on board. I don't get arrogant like that, but I get incredibly protective, and I get triggered. I bring it up to my therapist. She's working on it with me. Because I do. And I hate a bully. And I hate when you guys get bullied into things. I get triggered that way. So when you see me get upset in these reels or in these videos, it's because I'm remembering when I've seen things go wrong for someone, and I'm feeling that woman in that moment. I hope this information is going to be of service to you. I'm going to continue working very hard at being clear with you and communicating better every time. Because I watch that stuff and I realize some of it, I sometimes get stuck in jargons and I get in things. And I want you to know I'm going to work very hard at this always for you, because this does help me become a better physician, a better care provider, I think a better man, a better human. The next series I'm going to do is going to be on testosterone. And I'm going to talk about it very similar. I'm going to do why I would use testosterone in a woman, because it is controversial still in some places. I'm going to talk about the routes of delivery. First of all, the reasons why I use it, how I would deliver it, what the response I'm looking for, what are the benefits I want with it. Then I'm going to talk about, as I mentioned, the different delivery methods. I'm going to talk about why one is better than another, or what to do if you're stuck with one delivery system, how to manage the side effects that come from that. How do you test for the side effects? So that's the pharmacokinetics. I'm going to really work at this to the degree I'm good at it. I want you to let me know because I want to keep getting good at this, as I mentioned. All right. So, again, I hope this helps. I appreciate you being here with me in this space. And I appreciate you welcoming me into that space when you speak to one another and you care for one another. I know that's a very special place to be welcomed into. Thank you. All right. I'll catch you the next time.